Hello, everyone. Dr. Nikhil Verma here with another episode of Things I Didn't Learn in Med School. Today, I want to talk about the patient journey and essentially what occurs from a patient looking you up on or getting a referral over to you to the end portion of how you actually get paid. I've talked about some of these things in the past, but I kind of want to make a summary of all of it, mainly because I was thinking about it this week, and this is definitely something that we didn't learn much about in the past or in med school. Like, you would just put in an order and poof, magically the x-ray appeared. So I kind of want to talk about how the process goes. I'm going to surely miss some steps, but I'm going to try to be as thorough as I can. So I guess the first step after you've opened your practice would be a patient coming to find you. So there's one of two ways. Either you have good community relations and a physician or a colleague will refer a patient to you, or a patient will search you online. Not all specialties in all states need referrals. Some specialties don't. Some patients can directly refer themselves. And this also gets a little tricky when we have insurance companies too, because certain insurance companies or certain insurance plans will require a referral to be seen by a specialist. So that's something to keep in mind. Every state's different. Every insurance company is different. So that's one thing to keep in mind. The next thing on top of that, though, is the patients, if they search for you themselves, like, how does that work? So that essentially means that you need to have a good website. You need to have some sort of online presence as far as a WebMD profile, HealthGrades profile. If you're with a hospital system, you have to make sure all that stuff's up to date. So that's one part of the picture of just before the patient even comes through your door is how are they going to find out about you? I would venture a guess that more than 90% of our patients will Google search us before they come to see you because they want to know, are you reputable? Do you have good reviews? Are you nice? Are you able to answer the questions that are brought up? All these things matter to the patients. And I guess it would matter to me too. It's not just for physicians, but it's for everything. You always want to check reviews. You want to make sure that whatever your service that you're getting is a good service. So say that the patient wants to schedule with you. Fantastic. So the first thing you need to do is register the patient into your electronic medical record system. So usually this just involves date of birth, name, address, phone number. Email address is becoming more and more common nowadays because a lot of patients are registered through their email and they'll get updates, which is an interesting point because now, or it reminds me that Cleveland Clinic is starting to charge patients if they want to message their physicians, which is great. Now the physicians might not get so much a burden of the messages that they can answer to, but I highly doubt any of those physicians are getting any of those money. It's just a way for Cleveland Clinic to make more money. That's another topic for another day. So registering a patient, the next thing they'll need is they're going to need to provide an insurance information. When they provide their insurance information, most insurance companies now have an electronic way to scrub and make sure that, hey, this patient is eligible to be seen by you. So you'll get a response, eligible, not eligible, or unverifiable. If it's unverifiable, you have to figure out, did I spell something wrong? Did they have a different surname? Was the birthday correct? All this stuff. And it can be a hassle sometimes because there's so many products out there and you can be battling for a long time. But some companies don't have that online portal or their portal system's down. So what do you do then? You can look online yourself, you or your employees, or worst case, maybe not worst case, but last case is we will pick up the phone and have to call the insurance company and see what kind of benefits we can get, and if we're a network or not. So already, again, before the patient has even stepped foot into your practice, look how many steps are involved just to make sure that the patient is able to come in, let alone the scheduling. Is it a schedule that works for the patient as well as the physician? Quite often it's, especially in pain management right now, there's pain management booking out 2 to 3 months out in the Central Ohio region, which is, a long time to go with if someone's suffering from pain. And I don't think people realize like all these steps also have to go into getting the patient on the schedule. Now, with that being said, not all patients will show up. So you have to usually add in another layer of patient reminders. Most electronic medical record systems, can't talk this morning, EHRs will be able to auto send a text or call or send an email. Most places utilize all three at suggested best practice ratio or best practice intervals. And this helps decrease patients not showing up for their appointments. But if you don't have those in your medical record system, you have to have a system in place, whether that be an employee or some sort of other automated system to help you. So that's another part of the journey. Now, I'm very conscientious. I don't always want my patients to be like, I'm overwhelmed with all these text messages and stuff. So I try to limit as much as I can. A lot of patients opt out, which is great if that's what they choose. I opt out of those reminders for myself because I usually put in my calendar right away whenever I schedule something. But, everyone's different, and, we can't afford to keep having patients not show up. So say, when the patient does come to your office and does come to see you, well, I just pause there just for a second because, think about this in the hospital system, or if you're with a big group, you don't worry about any of that stuff. It's all taken care of for you in the background. All of a sudden, a patient pops up on your list, new patient, new referral. Great, perfect. So, but if you're in private practice, you really need to realize what steps are involved because each one of these steps brings on its own problem, its own roadblocks, and can delay the care that we need to give our patients. So following that, I would say the patient, gets on the schedule and comes to see you. You have online paperwork or intake paperwork that needs to be completed. That's another barrier. But, this intake paperwork includes a lot. Past medical history, past surgical history, family history, et cetera, et cetera. But then you have to see what medications are on, what previous imaging they have. Do they have notes and stuff and imaging from other physicians that have ordered? X-rays, MRIs. You have to gather all this data. So, did the patient send it over before they came? Or do you have to pick up the phone and call that physician's office and have them send it over? Or does your medical record system communicate with another medical record system so you can download that data and siphon through what you need to siphon through? I've switched to an electronic version of this, and that's another burden I put on my patients that I hate to do, but it does make my time go more smoothly, and I have more time with my patients when this happens. So that's when the patient finally comes into your office and all that stuff. And then that's another section where I recommend checking insurance to make sure the insurance is still eligible and all that stuff because insurance companies change, patients might lose their job, they might lose their benefits. All these things come into play. So now you take the patient back to the room, your MA or whatever assistants you have available. They do their portion of history, exam, and et cetera. And then you come in and do your portion. So now this is where I want to briefly talk about billing because back before 2021, a lot of this was based off of either strictly time of face-to-face encounter with the provider and the patient, or based off of how many systems that you examined and how many review systems you do, how many physical exam maneuvers you did. And it didn't really make sense to do it that way. So in 2021, they changed it to medical complexity. So it's how much time did I spend total on this specific case. So sometimes the case will take me half an hour to get through the very beginning of just chart review and talking to the patient and then writing a note. So all these things matter. And if I call a physician that same day, all this has to be in the same day. You can't do it, split up 5 minutes, and bill at a higher rate. Or more likely what I do is the complexity of some of the cases that we have, I make sure I talk about every single complex case that we talk about. And then I also make sure I'm putting those as diagnoses and say what we discussed about it and what the next options are. Most specialties should be falling in the 3 to 4 range, if not the 5 range, especially for highly complex patients. And this is level of coding. That's a topic that could take 2 hours to talk about in itself. But I think the problem was in the past, a lot of physicians were billing for 3s and 4s without really doing anything else complex medically. Like they would just say, oh, someone comes in for knee pain, but they would do all this review systems, all this physical exam stuff, and they would still bill for a level 4. So I think that's what they were trying to cut down on. So, so this stuff matters because at the end of the visit, you are going to submit your billing to the insurance company. Now, the insurance company is going to review it and say, yes, we approve it, or no, we're not going to approve it. And I'll talk about that at the end of this video about appeals and all that kind of stuff. So just keep that in mind. So you see a patient and say you want to order a medication. So most medications that are generic will be covered by most pharmacies and most health insurance plans. But some health insurance plans prefer certain medications over others, like cyclobenzaprine versus tizanidine. Both are muscle relaxers. Both have similar effects, but I prefer cyclobenzaprine for a lot of my patients because it has a TCA effect, tricyclic antidepressant effect, and it can help with sleep structure better than tizanidine. Tizanidine works a lot better on the alpha stimulation of muscle spasms and in the central nervous system. It can also help lower blood pressure, some other stuff involved. So, that's just a personal preference. But I've had a lot of denial. Some insurance companies saying, we don't cover this, please consider tizanidine. Or another problem that comes up is, did you weigh the risks of abuse potential with these medications? Which, when it comes down to abuse potential, the abuse potential of muscle relaxers is so low. I can't believe it's like a warning that comes up every single time I try to prescribe it. I do understand when you're over the age of 65, it increases your risk of fall and that kind of stuff. But also, there's a lot of things that can increase your risk of fall. I don't know if it's these medications in specific. So I recommend usually taking them as needed at night when you're not up and walking around, usually before you go to bed. Again, because of that sleep infrastructure thing. So that's for medication. Say you want to get an x-ray done. Again, at the hospital system, when I was working in residency, it's just like, oh, just type in the order, x-ray. All right, patient, go get your x-ray taken care of. Well, what I didn't realize is like it's way more complex than that. So I ordered an x-ray, and first off, do you usually need prior authorization or not? 99.99% of x-rays do not need authorization. So one of two ways this happens. I can send the order to the imaging facility. The imaging facility is not going to waste their time to call and schedule the patient, though. Most of the time, they're just going to say, come walk in, because x-rays are relatively easy as long as they have an order. But some facilities, because they don't schedule the patients, they don't want you to send it to central scheduling. They just say, print off a script or write down a script and hand it to us, and we'll take care of it. And that's where the x-ray portion comes into play. Now, if you're ordering your own x-rays and you're interpreting your own x-rays, that's a whole nother level of billing that can be involved if you adequately can do x-rays in your office and bill appropriately because you've done the interpretation. Say you want to say you want to get an MRI or a CT scan, that might need a level of prior authorization. Most insurance companies are requiring our patients to have 4 weeks of physical therapy or chiropractic therapy, 4 to 6 weeks. Tried 2 different classes of medications in that 4 to 6 weeks, have tried other conservative measures, and they're failing that before they're going to approve an MRI or CT scan for back pain or neck pain, that kind of stuff. Unless there's a life or limb or severe neural compromise. Those you can get approved pretty much right away. But other ones, you're taking your time to get this approval. So in this process, it either gets approved because, hey, perfect, everything's good. And then that is sent to the imaging facility. The imaging facility calls the patient, they get it scheduled. But sometimes the imaging facility will take care of the prior authorization themselves, which helps the process, but that doesn't always happen. So sometimes you or your team has to get the prior authorization for that patient. It adds another layer of complexity and adds an extra step to get our patients the care that they may need. Next, we talk about if it gets denied. So if it gets denied, you can either sometimes just edit your notes and send that over, and because you forgot to add what conservative therapies they had or what medications they had, it's fine. But some insurance companies require peer-to-peer. You have to set up a time to set up a peer-to-peer and talk with the physician and say, hey, this is what's going on. What do you think? They're either going to say, yes, I agree. I'm sorry that, we just didn't see that in your note, or you didn't add that to your note. Please add that in and fax us over. Or they're going to say, no, it's still denied. So if it's still denied, then you have to play the game and figure out how you can get it approved in the future. If it gets approved, then you write down the number, call the imaging facility, and let them know. Now, each imaging facility has their own TIN number, tax identification number, and its own NPI. So if I get an MRI approved at the facility down the street, and my patient's like, no, I don't live that area, I live on the other side of town, I would potentially need to do that whole process over again for that other imaging facility. Some insurance companies are super friendly about this, like, no problem, we'll just change the service. Like others are like, nope, new referral. So again, another nuance that I didn't know existed in med school. Not only just prior authorization, but how that worked and how to get a patient in and how much time doctors are doing on the back end to get these prior authorizations taken care of. Now, say you want to do a procedure for a patient. Getting procedures done in your office, say an epidural steroid injection, a lot less tedious, a lot more, based off of the notes. As long as everything's accurate, you can get it taken care of. But if you want to do it at a surgery center, again, you have to go get a prior authorization. Now, this does fall on the physician and his team or her team that want to get that procedure done. They will need to get the prior authorization. The surgery center is not going to get it for you. No one else can get it for you. So you either have to do it yourself, outsource it to a company, or find a way that, or do it yourself, right? Or your team does it for you. All these things are the same end result to try to get this patient the procedure that they may need. The other side is some patients will require sedation for these procedures. Sedation isn't always required to get authorization, but say we're doing a kyphoplasty or a spinal cord stimulator trial, sometimes the facility would like a prior authorization for their surgery, for their anesthesiology group to do the anesthesia. Usually the anesthesia group will get it themselves. I ran into a case or two that the anesthesia group has asked me to get it for them, which is completely unfair for me, in my opinion, completely unfair for my team. I've pushed back against this. We're kind of stuck in a stalemate about this right now, but if that's what we need to do for this surgery center to function more properly, that's fine for the time being. So that's kind of the 3 steps of like medications, imaging, advanced imaging, and procedures. Now, this is last 5 minutes. I just want to talk about billing and how that kind of goes down. Or even post-procedure. Let's start there, because that'd probably be the next step in the, say there's a complication and a patient wants to call in and talk to you or talk to someone at the practice. This is where the front desk needs to be very, very trained to answer the question appropriately, or an office manager that can complain or can take the phone and help the patient out. Or if you're not available yourself to talk to the patient, at least have some sort of answering service to help mitigate and triage the issues that come up. That could all help alleviate some problems, but the big thing is, like, these are things that you need to think about and have systems in place beforehand. So yeah, I want to talk about billing now, because that'll probably be the next thing in the next step in the series. So when you submit a billing to the insurance company, a few things can happen. A few things will happen. One, they're going to take a look and say, are you a network or not? Did this procedure have a prior authorization? Did you have a referral? All these things matter, because they'll deny it for any of these reasons. Say they deny it and I had a prior authorization, you simply have to appeal, and under the appeal process, wait for them to return the appeal process. They can deny it altogether because you did the wrong procedure, or you typed in the wrong code for the wrong diagnosis for the wrong code, which has happened to me. I had the wrong kyphoplasty or wrong diagnosis for a kyphoplasty, and I've edited it 3 times, and we're still waiting for the payment, despite us sending appeal after appeal after appeal. And you can only appeal 1 to 3 times sometimes. So that's something to keep in mind of why you need a good billing team, or you need to be pretty much very, very masterful at your own billing, so you know what's going on. So that's what happens with some of the denial scenarios. And that's not an exhaustive list. There's tons more. Another thing you're going to see on the EOB, the explanation of benefits, is an adjustment. So my contracted rates for what I charge for an epidural steroid injection is not what the contracted rate with the insurance company is. So there's going to be an adjustment where, say it's $350 for an epidural, and they adjust minus $250 off it. So I'm going to get paid $100. So the insurance company either covers 100% and sends it, or in more cases, what happens is there's a co-insurance involved. So I'll get $80 from the insurance company, and then the patient owes me $20. And we won't know that until the end. In some cases, when there's the denial altogether, the insurance company says, no, we're not covering any of this. That all falls to the patient. So as a practice, you have to figure out what to do. Am I going to charge my patient cash or charge a patient? Or am I going to go back and write this off? And this is a very tough decision for a lot of physicians to do because you have to operate in a business. Now, this is why hospital systems and big orthopedic groups or big groups have master groups that can help navigate all these steps along the way, to help denials and appeals and all that stuff. There's sometimes patients just want to pay cash straight up. So, you work out whatever your cash pricing is for these things and let them know, and then they can pay and you don't build insurance anything. In my opinion, this is where advanced medicine is going to go in the future, and even primary care, unless we do something drastically different in our current landscape of insurances and healthcare industry. That is the short and sweet version of billing and how some denials can come through and what to do about it. But again, you need to know where the hiccups come, because when they come, you need to know how to navigate through it and help yourself. And then at the end is, are your patients getting a satisfactory results from this? So this is the time that you either reach out to your patient and say, hey, would love if you had a good experience, to leave a review. And to be active in those conversations with your reviews to make sure that, hey, I appreciate you reaching out. I appreciate the review. It means a lot to us. However you want to word it is probably good. But you need to be sincere about it. You can't just oh, thanks. Every time a patient does, I take the extra step to make sure I write something out. And this is also a good time to reach out to patients during the holidays and that kind of stuff to say, hey, we're still here for you if anything comes up during the holidays, or if you need anything, please let us know. And sometimes this is where a handwritten letter can go a long way for especially patients that may be suffering from different ailments throughout their years and need to come back to you on a consistent basis. Monitoring your reviews. So if there's a negative review, how are you going to handle that? Are you going to let your office manager handle it? Are you going to call the patient? Are you going to set up a time to talk to the patient? All these things do matter, and everyone's going to get bad reviews, so you need to know how you're going to navigate it in the front end, so it doesn't become so burdensome for you. And then that's the other thing on the billing side. If a patient does end up getting a co-insurance, or the insurance company only covered this much and the rest is fell into the patient, you need to have ways in place to help navigate through that and tell the patient what to do and how to do it. Or are you going to write it off? All these things, again, matter a lot, and people don't think about it. So think about this, from the beginning, from when the patient looks you up first online to the end when they leave a review and or have a question about their billing. Usually all these things are filled in by somebody in a hospital system, or a group of people, or an individual doing multiple of these things. In an office, it's not so cut and dry, and everything is just lined up perfectly. A lot of times I'm the one getting the prior authorizations or calling to schedule my patients for a procedure, or all these things. One thing I forgot to mention about in a scheduling procedure is, most of the surgery centers require a surgery request form. So you have to fill out the surgery request form and fax it over just to get your name on the schedule. This is something I never even realized in fellowship that this happened, that the front desk was working on, or maybe the back office was working on without my knowledge. And that became a big deal for me because I didn't know what to do with it. And now I'm learning to, every procedure I want to do, there has a request form that you need to know the diagnosis, the CPT codes, the ICD-10 codes, what side, health conditions of the patient, allergies, all that stuff. It matters. Do they need medical clearance or not for this certain type of procedure? So you need to fill all this out and fax it over beforehand. Again, all these things have people in place usually to take care of. But when you're in private practice, you're the one taking care of this, or you've outsourced it because of the amount of time that would take you to do these kind of things. is not as significant as the amount of procedures or patients you could see. So it's a push-pull barrier to see how much you can help yourself to help the practice. Right now, since I'm not so busy, I do a lot of this stuff, but I have started outsourcing over the past few months because it's becoming too much for me to handle that, plus seeing patients, plus doing procedures. But I'm doing the best I can to help my staff out whenever I can. Usually I come in pretty early. I come in about an hour and a half before our clinic opens, so I can take care of whatever I can take care of. A lot of times I'm taking care of peer-to-peers and appeals to denials for procedures and stuff. So I also always check my billing statements for the past couple weeks to make sure that there's nothing glaring or miscode or something like that I can take up quickly. Otherwise, my billing team will let me know what's going on. So the only thing I want to close on is, I was talking to my friend the other day. I'm like, yeah, it's going okay. I just don't know how many people actually watch it. And I've gotten a lot of good remarks about these things. So I was like, you know what? And he said, you know what, man? You can't help the people that don't want to help themselves. You're just putting out information. If people want to accept it, that's great. If they learn from your mistakes, even better. And I think that's kind of another reason what inspired me about today's talk. It was just like, this is information I wish I knew I had, or I wish I had prior to starting my practice. It would have helped me immensely. I still think I would have had to go through the pains and pitfalls of all this stuff, and just to understand it a little bit better. But I am starting to understand it a little bit better. I am starting to live it much more than I would have if I went into a practice first and came into the private practice sector later. But also, the thing with this is, I am nowhere near done learning about any of this stuff. I always use the Dunning-Kruger effect, where you think you're an expert and then you come crashing down. I always constantly think about this because, once you're at your peak of the peaks, what's going to happen is something's going to come up and it's going to be so hard for you and challenging for you that you're going to tumble down. You're going to feel like you don't know anything. You're going to feel like it's all stressful. And then you start reading, you start learning again, you start asking better questions, and that starts getting you back up that hill. And then you become complacent, or you start understanding like this is going to happen again. And the cycle repeats over and over again. So I'm just hoping that I'm putting you guys on base so you can take whatever I'm taking to the next level. Being a successful practice, however you want to do it, at least you know the ins and outs and how the patient's journey itself went through. So you can, if nothing else, better serve yourself to better serve your patients. And that's my big overall message, is I want to be able to help so many more people that I can help myself. That's the whole purpose of making these videos. I'm not charging anyone anything. I'm not asking anyone to follow me. Specifically, if you follow, subscribe, because you do, that's fantastic, but I'm not forcing anyone to do any of these things. I'm doing this out of my own time because I really do think that this is my most effective way to help more people. I'm only one person. I can only see one person at a time. I can only be at one place at a time. But if this information gets out to other people, and then other people can disseminate this to more people, then my indirect effects will be totally worth it in the end. So anyways, everyone, I hope you guys have a great weekend, and we'll talk to you soon. Thanks. Bye.